Medicare just changed, not in subtle ways that only policy experts notice, in fundamental ways that will directly affect how much you pay, what's covered, and how you access care starting right now in 2026. Some of these changes will save you thousands of dollars. Others will cost you hundreds or even thousands more than you paid last year. And if you're not paying attention, you could miss critical deadlines, lose coverage you're counting on, or make enrollment decisions that lock you into the wrong plan for an entire year. I'm talking about 9 specific Medicare changes that took effect on January 1st, 2026, or will take effect during this year. These aren't proposed changes or possibilities. They're law, they're happening, and every single Medicare beneficiary needs to understand how these changes affect their coverage, their costs, and their healthcare decisions. We are on a mission to reach 10,000 subscribers to build a community that is aware of these financial shifts. If that resonates with you, hit subscribe. What I find so deeply troubling about these changes is how little attention they've received. Medicare serves over 66 million Americans, yet most beneficiaries have no idea their coverage just fundamentally changed. They'll discover these changes the hard way when they go to fill a prescription and face an unexpected $615 deductible, or when they need a procedure and suddenly face prior authorization delays, or when they realize the Medicare Advantage benefits they thought they had are no longer available. This information vacuum creates real danger for retirees. Some will overpay because they don't know about new benefits. Others will face financial shocks from unexpected cost increases, and many will simply continue with their current coverage without realizing that better options exist under the new rules. Let me tell you, understanding these 9 changes isn't optional if you want to navigate Medicare successfully in 2026. Let's start with a change that's going to hit millions of beneficiaries immediately. The Medicare Part D prescription drug deductible has increased to $615 for 2026, up from $590 in 2025. This might sound like a modest $25 increase, but here's what it actually means for your wallet. The Part D deductible is the amount you must pay out of pocket for covered prescription drugs before your plan starts sharing the cost. Not all Part D plans have a deductible. Some have $0 deductibles, but many plans, especially lower premium options, require you to pay the full deductible before coverage kicks in. If you take expensive brand name medications, you could be paying $615 entirely out of your own pocket in January and February before your plan pays anything. What I find particularly frustrating about this increase is how it disproportionately affects people on fixed incomes who take multiple medications. A retiree taking 5 prescriptions that cost $150 each will pay the full $615 before the plan contributes a dollar. That's a significant financial burden in the first months of the year when many retirees are also dealing with property tax bills, higher heating costs, and post-holiday expenses. This increase is part of a pattern. The Part D deductible has risen from $480 in 2021 to $615 in 2026, a 28% increase in just 5 years. These annual increases are set by law and indexed to per capita drug spending, which means they'll continue rising faster than general inflation. For beneficiaries on tight budgets, this creates a growing affordability problem at exactly the time of year when cash flow is already strained. The strategic implication is that you need to carefully compare Part D plans during open enrollment. Plans with $0 deductibles typically have higher monthly premiums, but for people taking expensive medications, paying an extra $30–40 per month in premiums to avoid the $615 deductible can be a smart trade-off. Run the numbers based on your specific prescriptions rather than defaulting to the lowest premium plan. The second major change affects people with very high prescription drug costs. The Medicare Part D out-of-pocket maximum has increased to $2,100 for 2026, up from $2,000 in 2025. Once you've paid $2,100 out of pocket for covered drugs, you pay nothing more for the rest of the year. Your coverage becomes completely free. Now, this change comes with important context. Prior to 2025, there was no true out-of-pocket cap on Part D spending. Beneficiaries could face catastrophic drug costs running into the thousands or even tens of thousands annually. The Inflation Reduction Act created this out-of-pocket cap starting in 2025 at $2,000, and it's now increased to $2,100 for 2026. For people taking very expensive medications, specialty drugs for cancer, rheumatoid arthritis, multiple sclerosis, or other serious conditions, this cap is genuinely life-changing. Before this protection existed, I spoke with beneficiaries paying $8,000, $12,000, or more annually for prescriptions. Now, once they hit $2,100, their drug costs stop. Every prescription after that point is free. But here's what concerns me about this change. The cap going up means you pay more before reaching zero cost. Someone taking expensive medications will pay $100 more out of pocket in 2026 than they did in 2025 before hitting the cap. For beneficiaries barely affording their medications, that extra $100 could mean skipping doses or cutting pills in half, behaviors that compromise health outcomes and often lead to more expensive medical interventions later. What I find particularly important is understanding how this cap interacts with the new Medicare prescription payment plan, which I'll discuss next. These two changes together create new strategies for managing drug costs that weren't available before. Here's a genuinely helpful change that too few beneficiaries know about. The Medicare prescription payment plan, which launched in 2025, now features automatic renewal for 2026. This program allows you to spread your out-of-pocket drug costs over monthly installments instead of paying everything up front. And critically, if you enrolled in 2025, you're automatically re-enrolled for 2026 unless you opt out. Let me explain how this works because it's a powerful tool for managing cash flow. Under the prescription payment plan, instead of paying your full drug costs when you pick up prescriptions, including that $615 deductible and any subsequent copays, you pay a monthly amount. Medicare calculates your estimated annual out-of-pocket drug costs and divides by 12. You pay that amount each month, regardless of whether you actually pick up prescriptions that month. Here's a real-world example. You take medications that will cost you $1,800 out of pocket for the year based on your Part D plan's coverage structure. Without the payment plan, you'd pay $615 for your deductible in January, February, then ongoing copays throughout the year. Very lumpy, unpredictable costs. With the payment plan, you pay $150 per month, $2,800, 12 every month of the year. Your costs are predictable, manageable, and spread evenly. What I find particularly valuable about this program is how it helps retirees on fixed incomes avoid the financial shock of that $615 deductible hitting all at once. Instead of struggling to come up with $615 in January, you're paying roughly $51 per month as part of your monthly payment. For many retirees, that's the difference between affording medications and skipping doses. The auto-renewal feature for 2026 means that if you were enrolled in 2025, you don't need to do anything. You're automatically continued in the program. Your monthly payment will be recalculated based on your 2026 drug costs, but you don't need to re-enroll. This is significant because it removes a barrier to participation. People who benefited from the program in 2025 won't accidentally lose coverage by forgetting to re-enroll. The fourth change is controversial but necessary. Medicare Advantage plans can no longer offer certain supplemental benefits that have nothing to do with health care. Specifically, plans can no longer advertise benefits that include alcohol, tobacco products, or unhealthy foods as covered items. This might sound trivial, but it represents a significant shift in how Medicare Advantage plans are marketed and what they can offer. For years, some Medicare Advantage plans have advertised increasingly creative benefits to attract enrollees. Grocery allowances that could be used for any food, including junk food and alcohol, prepaid debit cards with minimal restrictions, and other perks that had questionable health value. While these benefits looked appealing in marketing materials, they often came with trade-offs like higher copays, restricted networks, or aggressive prior authorization requirements that weren't prominently disclosed. What I find troubling about this practice is how it distorted plan selection. Beneficiaries chose plans based on flashy benefits like $900 grocery allowance without carefully comparing actual healthcare coverage, deductibles, copays, prescription drug coverage, and provider networks. They were lured by perks and then discovered their actual medical care was more expensive or more restricted than they expected. The new rule requires that supplemental benefits have a reasonable expectation of improving or maintaining the health or overall function of enrollees. This means benefits must be healthcare related. Plans can still offer gym memberships, over-the-counter medication allowances, transportation to medical appointments, healthy meal delivery after hospital discharge, and other benefits with clear health connections. They just can't offer alcohol, tobacco, or purely recreational benefits with no health nexus. The practical impact for 2026 is that some Medicare Advantage plans have reduced or restructured their supplemental benefits. If you chose your current plan partially based on grocery allowances or prepaid cards, you may find those benefits are less generous or more restricted than they were in 2025. This is actually a good reason to review your coverage during the next open enrollment period. Make sure you're choosing a plan based on actual healthcare coverage quality, not marketing gimmicks. Here's unambiguously good news, especially for the roughly 3.3 million Medicare beneficiaries with diabetes. The 35 monthly cap on insulin costs is now permanent. Previously established as a temporary measure, this cap ensures that no Medicare beneficiary pays more than $35 per month for each covered insulin prescription, regardless of the insulin's actual cost. This change is genuinely life-changing for diabetics who were previously paying hundreds of dollars monthly for insulin. Before the cap, some beneficiaries were paying $300, $400 or more per month for the insulin they need to survive. They were forced to ration insulin, skip doses, or use expired insulin, behaviors that lead to serious health complications, including diabetic ketoacidosis, vision loss, kidney failure, and death. What I find particularly significant is that this cap applies across all Medicare coverage, Part D plans, Medicare Advantage plans with drug coverage, and even during the deductible phase. You pay no more than $35 per covered insulin per month, period. If you use multiple types of insulin, you pay no more than $35 for each type, but most diabetics use one or two types, making the cap highly effective. The financial impact is substantial. A diabetic previously paying $250 per month for insulin now pays $35, a savings of $2,580 annually. For beneficiaries on Social Security incomes of $20,000 to $30,000 per year, that's 10% of their annual income returned to them. This money can now go toward other necessities, food, housing, other medications, rather than being consumed entirely by one drug category. This is reminiscent of what policy experts call a bright line rule: simple, clear, easy to understand and enforce. No complicated calculations or income thresholds. Every Medicare beneficiary with diabetes pays no more than $35 per insulin per month. The simplicity is part of why it works so well. The sixth change eliminates out-of-pocket costs for all adult vaccines recommended by the CDC. Starting in 2026, vaccines including shingles, pneumonia, whooping cough, RSV, and others are covered at zero cost under Medicare Part D. You pay nothing, no copay, no coinsurance, no deductible. Prior to this change, vaccines fell into a confusing split coverage scenario. Some vaccines were covered under Part B with no cost sharing. Others were covered under Part D and subject to whatever cost sharing your Part D plan imposed. The shingles vaccine, for example, could cost $150 to $200 per dose out of pocket depending on your Part D plan, and you need 2 doses. Many beneficiaries simply skipped vaccines they couldn't afford. What I find so important about this change is how it removes a significant barrier to preventive care. Vaccines for adults prevent serious illnesses that are both costly and dangerous. Shingles can cause debilitating nerve pain for months or years. Pneumonia can be deadly for seniors. Whooping cough can cause months of severe coughing and breathing difficulties. These are preventable with vaccination, but cost was preventing many beneficiaries from getting protected. The financial impact here is substantial. The 2 dose shingles vaccine series could previously cost $300, $400 out of pocket. The RSV vaccine, newly recommended for seniors, was running $200, $280. Pneumonia vaccines could cost $100, $200, depending on the type. Eliminating these costs means beneficiaries can now receive all recommended vaccines without financial strain. From a public health perspective, this change should significantly increase vaccination rates among seniors, which will reduce illness, hospitalization, and death from vaccine-preventable diseases. From an individual financial perspective, it removes $500, $800 in potential out-of-pocket costs that many beneficiaries were avoiding. Change. Number 7. Prior authorization in traditional Medicare. Here's a change that's more limited in scope, but significant for those it affects. Medicare is implementing prior authorization requirements for certain procedures in 6 states as a pilot program. If you live in one of these states and have traditional Medicare, not Medicare Advantage, you may now need to get approval from Medicare before receiving certain outpatient procedures. The 6 pilot states are not yet publicly confirmed for all procedures, but Medicare has indicated that prior authorization will apply to certain high-cost outpatient services that have been identified as having high rates of improper payments or unnecessary utilization. This could include things like certain types of imaging, outpatient surgery, durable medical equipment, and other costly services. What I find concerning about this change is that it brings one of the most frustrating aspects of Medicare Advantage, prior authorization delays and denials, into traditional Medicare, which has historically been far simpler to use. Traditional Medicare has operated on a pay and chase model where services are provided, Medicare pays, and if something was improper, they recover payment later. Prior authorization shifts to a get permission first model, which creates delays and administrative burden. For beneficiaries in these pilot states, the practical impact is that if you need certain procedures, your doctor will need to submit a prior authorization request to Medicare before providing the service. Medicare will review the request and either approve, deny, or request additional information. This process can take days or weeks, potentially delaying care you need. The good news, if there is any, is that this is currently limited to 6 states as a pilot program. If you're not in one of these states, you're not affected. But if the pilot is deemed successful from Medicare's perspective, meaning it reduces spending on improper or unnecessary services, this could expand nationally. That's why it's important to watch this development even if you're not currently affected. Change number 8, Medicare Advantage out-of-pocket maximum decreases. Here's some genuinely positive news for Medicare Advantage enrollees. The out-of-pocket maximum for Medicare Advantage plans has decreased slightly to $9,250 for 2026, down from $9,350 in 2025. This is the most you can be required to pay out of pocket for covered services in a year, excluding prescription drugs, which have their own separate out-of-pocket limit. Now, I want to be clear about what this means. Individual Medicare Advantage plans can set their out-of-pocket maximums lower than 9,250, and many do, with OOP limits of $3,000, $5,000, or $7,500. But no plan can set their maximum higher than 9,250. This is the ceiling, the worst-case scenario for cost exposure in a Medicare Advantage plan. What I find particularly significant about this change is that it's one of the rare instances where the maximum has actually decreased rather than increased. Healthcare costs rise every year, and typically these maximums increase to reflect that. The fact that it decreased by $100 suggests Medicare is trying to provide some modest relief to beneficiaries facing high medical costs. The practical impact is limited but real. If you have a serious health event in 2026, major surgery, cancer treatment, multiple hospitalizations, and you hit your plan's out-of-pocket maximum, you'll pay up to $100 less than you would have in 2025 if your plan was at the maximum limit. For someone facing a health crisis, $100 matters. What's more important is understanding that this out-of-pocket maximum is your safety net. No matter how expensive your care gets, you have a cap on your financial exposure. This is actually better protection than traditional Medicare offers without a Medigap policy, because traditional Medicare Part A and B have no out-of-pocket maximum. The 20% coinsurance on Part B services can accumulate to tens or hundreds of thousands of dollars for catastrophic health events. The ninth and potentially most impactful change is that Medicare Part D plans are now required to cover certain GLP-1 medications, drugs like Ozempic, Wegovy, Mounjaro, and Zepbound, for weight loss when prescribed for obesity with related health conditions. These drugs have been revolutionary in treating obesity, with patients losing 15–20% of body weight on average, but they've been prohibitively expensive, often costing $1,000, $1,500 per month. Under the new coverage rules, Medicare Part D plans must cover these medications when certain criteria are met. Typically, this includes having a BMI over 30, obese, or over 27, with weight-related health conditions like diabetes, heart disease, or high blood pressure, and other conservative measures have been tried first. The coverage comes with copays around $50 per month, making these drugs accessible to beneficiaries who could never afford them at full price. What I find particularly significant about this change is the scale of impact. Roughly 40% of Medicare beneficiaries are obese, and obesity is directly linked to heart disease, diabetes, stroke, joint problems, and many cancers, the leading causes of death and disability among seniors. If even a fraction of these beneficiaries can successfully lose significant weight with these medications, the health outcomes could be transformative. The financial implications are complex. From a beneficiary perspective, spending $600 per year, $50 copay x 12 months, to lose 30–50 pounds could prevent thousands in future medical costs from obesity-related complications. From Medicare's perspective, covering these drugs will cost billions, but could save even more by preventing expensive hospitalizations and chronic disease management. What I want you to understand is that this coverage isn't automatic or universal. Your specific Part D plan must cover the medication your doctor prescribes, and coverage is subject to prior authorization. Your doctor will need to document medical necessity. Not every beneficiary who wants these drugs will get them covered. But for those who do qualify, this represents potentially life-changing access to medications that were previously financially out of reach. Let me be very direct about the action steps you need to take based on these 9 changes. Review your Part D coverage. With the deductible increase to $615 and the out-of-pocket cap at $2,100, run your actual prescription costs through the Medicare Plan Finder at medicare.gov. Compare plans based on your specific drugs. A plan that looked good in 2025 might not be optimal for 2026. Enroll in the prescription payment plan. If you face high out-of-pocket drug costs and struggle with the uneven cash flow, enroll in the payment plan. It spreads costs evenly throughout the year. If you were enrolled in 2025, you're automatically continued. Verify your monthly payment amount is correct. Get your vaccines. With all adult vaccines now free, there's no reason to delay. Schedule your shingles vaccine if you haven't had it. Update your pneumonia vaccine. Get the RSV vaccine if recommended. These are now zero cost and could prevent serious illness. Verify insulin coverage. If you use insulin, confirm that your plan is properly applying the $35 cap. Check your first prescription fills in January to ensure you're not overcharged. If you are, contact your plan immediately. Check your Medicare Advantage benefits. If you chose your current MA plan based on supplemental benefits, review what's actually still available in 2026. Some plans restructured their offerings after the junk benefit elimination. Make sure your actual healthcare coverage, networks, copays, drug coverage meets your needs. Understand prior authorization. If you live in one of the 6 pilot states for prior authorization in traditional Medicare, talk to your doctor about what services might require pre-approval and build in extra time for any planned procedures. Ask about GLP-1 coverage. If you struggle with obesity and related health conditions, talk to your doctor about whether these weight loss medications are appropriate for you and whether your Part D plan covers them. Prior authorization will be required, but the health benefits could be substantial. What I want to leave you with is an understanding that these 9 changes represent a Medicare system in transition. Some changes, like the insulin cap, free vaccines, and weight loss drug coverage, genuinely improve access and affordability. Others, like increased deductibles and out-of-pocket caps, shift more costs onto beneficiaries. And still others, like prior authorization expansion, make the system more complex and bureaucratic to navigate. The consistent pattern is increasing complexity. Medicare used to be relatively simple. Part A for hospitals, Part B for doctors, maybe a Medigap plan, and you were covered. Now you're navigating Part D drug coverage with formularies and coverage gaps, Medicare Advantage plans with networks and prior authorization, prescription payment plans, supplemental benefits rules, and constant annual changes to costs and coverage. This complexity isn't accidental. It reflects policy choices about how to manage Medicare's financial challenges, essentially by shifting costs and administrative burden onto beneficiaries rather than addressing systemic healthcare cost growth. For retirees, many of whom are not digitally savvy or comfortable navigating complex bureaucratic systems, this complexity creates real barriers to getting appropriate care at reasonable cost. The 9 changes I've outlined aren't the end. They're just 2026's chapter in an ongoing story. There will be more changes in 2027, more in 2028, and every year after that. The only way to protect yourself is to stay informed, review your coverage annually, and make proactive adjustments rather than passively accepting whatever plan you enrolled in years ago. Medicare is not a set it and forget it system anymore, if it ever was. Your financial security and your health depend on staying engaged with these changes.